Picture a needle stick injury from a patient known to be positive for hepatitis B. Now, picture a human bite from that exact same patient. Which scenario terrifies you more?
Oh, I mean, clinically, most people instantly think of the bloody needle.
Right. Your clinical instincts scream that the needle is the ultimate threat. But if you're taking the boards, you have to know the human bite is actually like 20 times less likely to transmit that virus.
Yeah, but on the flip side, that same human bite will irreversibly destroy your articular cartilage in a matter of hours if you don't intervene perfectly.
Exactly. So look, if you are listening to this right now, you are likely a plastic surgery resident deep in the trenches of prepping for your board exams, like the FRCS.
And you really don't have time to waste.
No time at all. Today's deep dive is a rapid-fire, high-yield question and explanation review of hand infections and trauma. Press follow right now so you don't miss our future revision material, and rate the show if you learned something today.
Yeah, please do.
Also, grab a premium subscription to access our exclusive Journal Club and Clinical Cases deep dives. You're going to need those.
You really will. So to set the baseline for what we're talking about today, when you look at hand infections broadly, Staphylococcus aureus is the most common pathogen across the board.
Right. But the examiners know you know that.
Exactly. They aren't handing out free points for the most common bug. They want to test the nuances, the anatomical traps, and the mechanisms.
Which brings us perfectly to our first major threat, which is traumatic inoculations, because they present the most urgent threat to joint viability.
Oh,
Okay, let's unpack this. Break down the epidemiology of bite wounds for us.
sure. So dogs account for the vast majority, somewhere between 60 and 90%. Cats are about 5 to 20%.
And humans.
Humans are roughly 4 to 23%. But with humans, you have to divide them into two specific mechanisms. You have occlusal injuries, which is an actual physical bite, and then you have clenched fist injuries.
Right, the classic fight bite.
Yeah, the fight bite. It's arguably the most dangerous scenario you'll face on call. A closed fist strikes someone's teeth, and the teeth inoculate bacteria directly into the joint space.
Which leads to septic arthritis.
Instantly.
I always think of the clenched fist injury like a sliding door mechanism.
Oh, that's a good way to look at it.
Yeah, so when the fist is closed, the tissues are taut over the knuckle, the tooth goes through the skin, the sagittal band, the extensor tendon, right into the joint capsule.
But then they open their hand.
Exactly. The fist opens post-impact, the joint extends, and all those contaminated tissues slide proximally. It literally traps the bacteria deep in the joint. So why is urgent surgical exploration so critical here?
Well, what's fascinating here is the sheer speed of the pathophysiology. Once that joint is sealed off, the trapped pus is basically an acid bath.
An acid bath, wow.
Yeah, it contains these proteolytic enzymes and toxins that actively degrade glycosaminoglycans in the cartilage. So you get rapid articular destruction.
And the microbiology is what makes it so destructive, right?
Yeah.
Human saliva has that mix of aerobes and anaerobes.
Exactly. You've got your aerobes like S. aureus, S. epidermidis, and streptococci. They consume the oxygen, which then lets the anaerobes thrive.
Like bacteroids and Pseudomonas. But for the boards, there's that one specific bug you have to know for human bites.
Eikenella corrodens.
Right, Eikenella.
It's a facultative anaerobe, meaning it can survive with oxygen but goes crazy when the aerobes deplete it. It destroys cartilage.
So surgically, how do we manage this for the exam?
Okay, exam answer. Urgent wide exposure. First, X-rays are mandatory to check for fractures or retained teeth.
Right.
Then you take wound swabs, put the joint through a full range of motion to recreate that sliding door effect, remove loose fragments, and irrigate aggressively. And crucially...
You leave it open.
Yes, you leave the wound open. If you close it, you're just recreating that closed anaerobic environment. And if they have persistent symptoms later, warn them it means osteomyelitis.
Makes sense. Let's briefly touch on animal bites. Dogs are puncture wounds, usually Pasteurella canis.
Yeah, massive tissue trauma, usually.
But cat bites seem so minor. Why do examiners love cat bites?
Because cat teeth are like hypodermic needles. They're so fine and sharp, they easily penetrate the joint capsule or bone with almost no visible surface trauma.
And the bug is Pasteurella multicida.
Exactly. The wound seals instantly, trapping P. multicida deep inside.
Okay, so transitioning from high-impact trauma, let's talk about everyday microtrauma. The infections where your anatomical approach is everything.
The stuff you see every day.
Yeah. Can you differentiate acute versus chronic paronychia for the residents?
Sure. Acute paronychia is the most common hand infection. Think manicures, nail biting. You treat it by just separating the nail from the fold or incising over the collection to drain the pus.
Simple enough, but chronic is different.
Totally different. Chronic affects people with constantly moist hands, bartenders, dishwashers. It's usually fungal, specifically Candida albicans.
You don't just drain it.
No, treatment is topical antifungals and steroids first. Keep the hands dry. But if you have to do surgery, you marsupialize the punctiniculum.
Got it. Now, what about the felon? It's a closed space infection of the finger pulp, right? Usually from a splinter or something.
Yeah, a penetrating wound.
Here's where it gets really interesting. Residents often just want to take a scalpel and poke a hole wherever it hurts.
Which is a terrible idea.
Right. So why is a high lateral drainage incision the gold standard for a felon?
It comes down to the structural anatomy. The volar fat pad has these vertical fascial septa. There are 4 reasons for the high lateral approach.
Okay, what's number 1?
1, it keeps the scar away from the tactile feeling part of the pulp.
Obviously important for a finger.
2, it prevents disruption of that specialized volar fat pad. 3, it minimizes the risk of hitting the neurovascular bundle.
And 4.
4, it gives you the exact right angle to go in and break down those fascial septa to decompress the compartments.
Because if you don't do it right, what happens?
Ischemic necrosis, osteomyelitis, septic arthritis, or it tracks up into a flexor sheath infection.
Wow. Okay, so moving from surgical emergencies to basically the ultimate board exam trap. A condition where a scalpel is your absolute worst enemy.
Ooh, I know exactly what you're going to say.
Picture a dentist presenting with throbbing pain and vesicular lesions on their index finger.
Classic herpetic Whitlow.
Superficial herpes simplex virus. You diagnose it with a Sank smear and viral cultures, right?
Yeah, and it's totally self-limiting, usually lasts about 2 weeks, though it can lie dormant and reactivate years later.
So what does this all mean for our residents on call? If the finger looks incredibly painful and full of fluid, why don't we just numb it and drain it?
This raises an important question, and it's the definitive exam rule. Surgical drainage is completely contraindicated.
Completely.
Yes. If you cut into those viral vesicles, you introduce skin flora directly into the deep tissues. You turn a self-limiting viral shedding process into a massive bacterial superinfection. Do not cut it.
Okay, message received. So let's zoom out a bit. We need to look at how infections track through the intricate fascial subway system of the hand.
The deep spaces.
Right. But first, flexor sheaths. Camon's 4 cardinal signs of flexor sheath infection. This is a guaranteed exam question. What's number 1?
Number 1 is fusiform swelling of the entire finger.
The sausage digit.
Exactly. Number 2 is a semi-flexed resting position of the finger.
To maximize the internal volume and reduce pain, right?
Yeah. Number 3 is tenderness over the actual anatomical course of the flexor sheath.
And 4.
Exquisite, disproportionate pain on passive extension because you're stretching that inflamed synovium.
Okay, so I always compare the flexor sheaths to a subway system.
It's the best way to visualize it.
Yeah, so if the thumb is the radial bursa train line and the little finger is the ulnar bursa line, where is the central transfer station? And how do we manage a horseshoe abscess?
The transfer station is the potential space of Perona.
And where is that exactly?
It's proximal to the transverse carpal ligament, sitting right between the flexor digitorum profundus and the fascia of the pronator quadratus.
So pus ruptures into it.
Right. It ruptures there and connects the radial and ulnar bursae,
creating the horseshoe abscess. So how do we treat it?
If caught under 24 hours, maybe IV antibiotics and elevation. Otherwise, you're doing an open decompression along the length or the closed technique.
The closed technique is the irrigation one, right?
Yeah, you irrigate through the A1 and A5 pulleys and leave a catheter in situ. If you don't, you're looking at tendon adhesion, necrosis, or losing the finger entirely.
Terrifying. Let's do a rapid fire on the deep spaces. The boards love these boundaries.
Okay, let's do it.
Thenar space.
Radial to the oblique septum.
Mid-palmar space.
Ulnar to the oblique septum, and it's continuous with the space of Perona.
Hypothenar space.
Rarely involved, but it's isolated on the ulnar side.
And the web spaces.
Ah, beware the collar stud abscess here.
Right, because it tracks volar and dorsal, right?
Exactly. And the massive exam pearl here is you never, ever use incisions that cross the web space.
Because of the scar contracture.
Yeah, it'll permanently tether the fingers.
Such a high-yield point. Look, we've covered bite microbiology, fight bites, felons, herpetic Whitlow, and all the fascial boundaries.
It's a lot of anatomy, but if we connect this to the bigger picture, Hand anatomy is uniquely unforgiving.
How so?
Well, unlike a thigh or an abdomen where swelling just expands outward, the hand is full of tightly packed, closed-space compartments.
Right, there's nowhere for the pressure to go.
Exactly. Microscopic bacterial enzymes basically dictate macroscopic structural collapse in a matter of hours. Understanding this anatomy isn't just for passing the FRCS.
It's real-world survival for the limb.
Yeah, it's a map predicting exactly how an infection will destroy the hand if you don't intervene perfectly.
Wow. That is a sobering thought to end on, but incredibly true.
Yeah.
All right, listen up. We're keeping this strict and no nonsense today. I want you to leave a comment or question right now on whatever platform you are listening on.
Yeah, let us know what you thought.
Let us know what clicked for you. And do not forget to secure that premium subscription for the clinical cases deep dives. You need them to crush these exams. Keep grinding, and we'll see you on the next deep dive.